So thank you very much. My name is Kim Cameron. I am on the faculty in the Management and Organizations Department and a self-identified positive organizational scholar. And we have been meeting, trying to learn from one another now for about 10 years, or 12 years maybe. The theme this semester is the application of these principles, positive principles, in other disciplines. And so today I'm really excited about having Afton Hassatt come. Afton is in the Health Sciences Medical School part of the university. She's an associate research scientist in the Department of Anesthesiology in a medical school. Well, I got to know Afton probably because in the last two meetings of the International Positive Psychology Association, I've been in sessions where she's presented some of her research. And at the end of the research, or maybe at the beginning of the presentation, somebody said, well, Afton Hassatt's from the University of Michigan. I thought, why don't I know this person? And it's just an indictment that we have lots of really interesting things going on here, and for the most part we get stuck in our disciplines or in our silos or in our schools. And so she is doing such interesting work. Her background, she got a degree at Colorado State University. I know exactly where that is. That's a beautiful country. And then her PhD in San Diego. She's since been at the Robert Woods Foundation. What is it? Robert Wood something Foundation. Robert Wood Johnson Medical School. Thanks. And studies interesting things that half of us in the room are going to suffer from. Chronic pain or fibromyalgia or rheumatoid arthritis or Lyme disease syndrome or will hurt sometime. And Afton is one of those core researchers in this, the Pain Research Center. Now, what's interesting about that for me is that when we first started the Center for Positive Organizations in 2001, I think it was either 2001 or 2002, the director of the center where Afton is currently doing research, Dan Claw, called us up and said, why don't we do a joint conference together? Because I can help treat or provide therapy for people who are suffering from pain, physiological pain. I can help that. But then they go to an organization in a work setting and it starts all over again because of the toxic environment that they're in. So it would be nice to have us inform one another, you from the organization side, me from the physiological side, about how we could try to help. We're kind of full circle because Afton is going to help us learn what's occurred in the last 10 years and how we can merge our work together. I'm delighted that Afton is with us, and I think we're going to learn a lot from her today. So, Afton Hassatt, thanks.
Thank you. Can you hear me? Is my microphone on? Okay, great. Well, this really is a treat to be able to address an entirely different audience. I don't know if Kim mentioned, but I'm a psychologist, so I'm a strange thing in the medical school to begin with, as it is, and so it's wonderful to be able to interact with a different group of people. So I'm most grateful for having you here, have me here to talk about probably my second favorite topic. My favorite topic is Michigan basketball, but that's a whole nother thing. Go Blue. So before we start, I have some disclosures. I do research that is funded by pharmaceutical companies, but predominantly the research we do is developing new outcome measures that look at resilience and quality of life. So after this invitation, I thought, how do I make pain research relevant to folks who are interested in business? And it became abundantly clear, like Kim was saying, we do think in our silos. The problem of pain is almost insurmountable. It is so huge. And so I hope to give you a sense of what that scope is and what it means to business and how businesses are greatly affected by their employees who have chronic pain. And then I'm going to do something that's probably quite a departure from what you're accustomed to, is I'm going to give you a peek into what we understand about pain. And a lot of this comes from fascinating studies that enlighten our knowledge of pain through neuroimaging. And then lastly, I'm going to talk a little bit about how resilience factors and positive psychotherapy types of interventions might actually save the day. Maybe. There's a lot of opposing forces. Okay. Oh, thank you. It's much better. That's good. Thank you. So when we think about chronic pain, it's many, many things. And so I'm going to talk about chronic non-cancer pain. These are conditions like fibromyalgia, chronic low back pain, headache, rheumatoid arthritis, osteoarthritis, many, many different conditions. And if you think about the people you know in your life, the people you love, and maybe yourself, you probably know or are somebody with chronic pain. Can I see a show of hands if you know somebody who suffers with chronic pain? Well, I think that's just about everybody, and that's probably just about right. So in an Institute of Medicine report that was released just about a year ago, they put out some incredible figures. It appears that about 100 million Americans suffer from chronic pain. That's actually more Americans suffering from chronic pain than those who suffer from heart disease, stroke, diabetes, and cancer combined. It's a huge problem. They estimate the annual cost to be between $560 to $635 billion a year, per year. And to put this into the context of what this might mean for business, for medical expenditures for federal and state governments, they're putting out about $99 billion a year. It's estimated that about 186 million workdays are lost each year to back pain alone. And about 13% of the workforce experiences loss of productivity over a 2-week period because of some form of chronic pain. Those costs are estimated to be about $95 billion. It's a huge, huge problem. So there are multiple factors that go into the genesis of chronic pain in a business environment. The first is the obvious. There's a dangerous workplace. There's a workplace that is not well suited to human beings functioning in it. And the causes of disability are the ones that you would expect. People who are lifting something that's too heavy, lifting it properly, pushing, carrying, throwing large items. Falls are a very, very common contributor to chronic pain initiation, as are being struck by or stuck against large objects. Now, these types of things don't necessarily happen as frequently in a regular business atmosphere, but there are many things like ergonomics and repetitive stress injuries that can contribute to chronic pain. And as Kim also alluded to, there's something that I think that's even more pervasive and pernicious. That's the toxic workplace. So when we look at the data about workplace bullying and harassment, it's clear that these two very stressful behaviors can lead to depressive symptoms, but also to physiological symptoms. In a really nicely conducted study of 1,913 healthcare and public service workers, they found that bullying was associated with pain, even if you control for depressive symptoms. So there's just this direct relationship between people who are being bullied in the workplace and the manifestation of chronic pain. In an estimate of how pervasive the bullying problem is, it was estimated in a study by Zogby in 2010 that about 35% of workers say, yes, they have been bullied in the workplace. So this is something very significant to think about in the world of business. So now that I've kind of set how big the problem is, I'm going to take you down a path with me to understand a little bit about what our little world of pain is like. Pain is weird. That's the first thing. Pain is really a riddle wrapped in a mystery inside an enigma. And that's a quote I stole from Winston Churchill, who was talking about Russia, which actually still kind of pertains today, right? So how we best can address the problem of pain really needs to be advised by these wonderful things that we are learning about the human brain. And I think I mentioned, too, that the imaging techniques are what makes this so exciting. This is called diffusion spectrum imaging. And this is a way that we can peek at not just structures of the brain, but the connectivities. What part of the brain is talking to what? And that seems to be almost more important than where things are occurring in the brain. So we've really come a long way. About 300 years ago, Descartes postulated that pain was a simple stimulus response. Something bad happened at A at the foot, and like running up a wire right to the brain pain spot, B, the second arrow, the message was received. And this was a prevailing theory for 300 years. Nobody thought much differently about it until the advent of some really, really smart thinkers in the 60s. This is a picture of Melzack and Wall. They're two researchers from McGill, but I also want to add the name Ken Casey, who was from the University of Michigan, a professor emeritus, who was very involved in rethinking what pain is. And Melzack and Wall first posed that the message just did run right up from the foot to the brain section. Some other things occur. There's actually a gating function. And this gating function is caused by the way we think about pain, emotions. It actually occurs at the dorsal horn of the spinal cord, that there is a way that the pain message can be slowed down, can be dampened, can be altered, and that's because of thoughts and feelings. And when Casey worked with these gentlemen, they really kind of broke down pain into three aspects that we can kind of see on neuroimaging. There's a sensory aspect, and a sensory, where it is, discriminative, what it feels like, is it tingly? There's an affective motivational aspect. What's kind of the emotional processing around it? What other types of more affective processes underlie? And then lastly, there's a cognitive evaluative process. What does the pain mean? Is it threatening? Is it scary? Is it bad? Is it awful? Is it ruining my life? And these three processes all contribute to the actual experience of human pain. And then what we learned is that there are neural structures that help account for this. So typically what we always thought, let me see if I can do my little arrow. There's my little dot up there. Okay, so the somatosensory cortex, that really is the seat of sensory pain. That is probably the closest we get to Descartes' little brain area, that the pain is processed there, the location of the pain is processed there quite clearly. But the other structures, the prefrontal cortex, anterior cingulate cortex, the thalamus, are highly responsible for processing the cognitive and affective aspects of pain. When somebody experiences pain, yes, the somatosensory cortex lights up, these other structures light up to varying degrees and in varying contexts. And then there's a structure called the insular cortex that our group spends a lot of time studying. And we're very excited about it because it's one structure of the brain that the anterior section of it processes affect, and the posterior processes the sensory aspects. And they talk rapidly. This is a very interesting convergence of the pain signal. And so using our ability to peek at brains, we've been able to come up with some interesting new truths today of how we think about pain. I think it was probably the phantom limb pain studies that really first got us trying to figure out what pain is and what pain is not. And so for those of you who may not have heard this, but when somebody loses a limb through amputation, through accident, or some other trauma, 80% of patients experience persistent pain in that limb and are pretty certain that limb is still there. There is, to them, a sense that the foot goes on and the pain is in the foot, even though the leg may be amputated. And for some of these patients, this causes tremendous disability. And what we've learned through our neuroimaging is that the representation of that foot is still there. In the brain where that foot one time made a pattern is still there. So the person really is feeling pain. That is not. And if we think about other forms of feeling pain that may not be there, they're the experiments that look at vicarious pain. And this was really interesting. They had subjects come in, and they let them feel the shock on the arm, very, very painful. And then they put them in a scanner, and they threatened them with the shock. And they looked at the part of the brain that lit up, and what happened when they thought they were about to be shocked, and were able to identify that pattern. Then what they did is they brought their friend in. And while the person laid in the scanner, they watched a video of their friend being threatened with the shock. And what they saw was the same pattern lit up, as if the person themselves were being threatened. So it was like they were experiencing the fear and shock. Then they brought in strangers, though, and the subject would see the stranger being threatened with a shock, and that pattern wasn't there. It was more like this emotional connection was there to really kind of experience this vicarious pain. So that was curious. So then they wondered, well, what happens with animals? Do animals experience this? So some researchers out of McGill University did a series of studies looking at mice. And so what they did is they took a little pain tester and they tested the pain on a mice by giving it a little shock or a little heat. And then what they did is they had the mouse watch its little mousy best friend, its cage mate, being withheld, being injured, being hurt, and then pain tested the mouse again. And the little mouse's pain was through the roof. In watching this other mouse suffer in pain, it caused that mouse to become hypersensitive. Now, when they brought in some stranger mouse and subjected it to being in pain, the mouse now no longer had the great sensitization. So again, it was the relationship. Is that mouse was connected to its cage mate. It had much more sensitivity. So this is just kind of a small smattering of sample of studies that tell us that maybe we can feel pain that's not there. Then there's this other curious case. Think about the athlete that has tremendous pain but doesn't feel it. Think about the concept of flow, and maybe you've experienced this yourself. Perhaps you're playing a game of tennis or doing something, and you walk off the court and think, oh my gosh, I really hurt my knee. How could I not have experienced that? And so there's been a number of studies that try and understand what is this process. How is it that when we can get so distracted and so into flow that we don't even know we're hurt, we don't even know we're injured? And I use this picture. This is Devin Gardner from last year's Ohio State game, where he played on a foot that was so severely injured that he was in a walking boot and on crutches for about 6 weeks after this. Told his teammates, I think I'm hurt. You might need to help a little bit, but he really was severely hurt but able to play. Oh, I have to show you something here. Some of the most interesting work that's been done in this area is done by Frankenstein. I just love that. So we as humans cannot sometimes not feel pain that is there. And then I bring you this study because it's interesting, but it was also done here by a faculty member at the ISR, Ethan Cross and his team. And they did something really interesting. They wanted to know what people who had broken up with their boyfriends or girlfriends looked like in a scanner. And so they advertised and they asked for the most horribly heartbroken individuals to come in for a study. And like all good neuroscientists, they stuffed them in a scanner to see what they look like. And so the very heartbroken were in a scanner, and they applied heat pain to their arms and got a pattern. What does this pain look like for this person? Okay, now we know what physical pain looks like for this person. Then they flashed up a picture of the ex-boyfriend or the ex-girlfriend and said, now we want you to think about your experience. And of course, conjuring all the, suffering and humiliation. And what they saw was a very similar pattern of pain. So they reacted to this emotional pain in a very similar neural pattern. And so I show you these brains because I won't spend much time talking about it because that would be unfun for people who don't do neuroscience, but they're cool. But I'll show you this diagram because basically what it does is summarize why this was such a fascinating study. We know that the sensory aspect of pain reliably lights up certain areas of the brain, predominantly the somatosensory cortex and the posterior insula. Remember that funny little section I told you we're so excited about studying? And then the affective aspects of pain reliably light up the anterior insula, the other part of that frontal insula that we were talking about, and the dorsal anterior cingulate. And then the emotional aspects of pain tend to light up other parts of the brain. What we saw in this study is probably for the first time these real physical pain sensors were lighting up to an emotional pain. And we had not really seen this before because I don't think we ever saw anybody who was in as much emotional pain as these poor people probably were who were being scanned. So a very intense emotional pain can look a lot like physical pain. So this tells us that the line between emotional pain and physical pain is blurry at best. I want to spend a couple minutes just talking to you about the dark side of pain. I think this is important because chronic pain is often thought of as not being really that big a deal. You know, if somebody has chronic low back pain, well, you know, it's not going to kill you. But what we're learning is that maybe it will. There's been a series of studies conducted by John McGrath and a really phenomenal group of epidemiologists out of Manchester, and they now have probably 7 studies that show that chronic pain is associated with a higher mortality rate. And in this study that I've featured here, people who have chronic regional pain are at a 20% greater risk of mortality than others, and people who have widespread chronic pain are at a 30% greater risk of mortality than other individuals. Now, the 2 lower studies I highlight because these came out about the same time. These were mortality studies looking at patients with fibromyalgia. I'm going to talk about fibromyalgia quite a bit. So is that a familiar term for you guys? Do you know what that refers to, fibromyalgia? Yeah? It's a chronic pain illness that appears to be due predominantly to central nervous system dysregulation. It's quite common. It's quite severe for the patients who suffer with it. So we wanted to look at, would having pain this severe be associated with mortality? And in both studies, the answers were negative. We found that the patients who had fibromyalgia were a much higher risk for suicide than just about any other type of mortality. So yes, they were at high risk for mortality, but not from the typical things like cancer, cardiovascular disease, etc. But as a co-author on the mortality study here over the 35 years, I will tell you that there were tremendous insights underneath these data, and they are reported in there. You just have to dig down a little bit. But what we did learn is that patients who actually met diagnostic criteria for fibromyalgia, in other words, had a little bit more severe pain, and patients who had more severe pain were indeed at a 65% increased risk of mortality. And they were at a risk of mortality from weird stuff: septicemia, influenza, pneumonia. And so we really didn't know what to think of it. Guys think, you know, why would these patients who are otherwise healthy die from illnesses that tend to take old people and children, that takes the vulnerable? Then it occurred to me, this is a very stressful way to live your life. Is it possible that this stress is playing, that you're paying a toll for living life with pain and disability and all the other things that go with that? So we embarked on kind of an incredible odyssey to look at a genetic marker in patients with chronic pain. So these are chromosomes, and the little shiny, happy illustrated top and bottom, those are telomeres. A telomere is a protein complex that caps the end of your chromosome. We all have them. They're very, very tough. They protect the chromosome from degradation, from end-to-end fusion. It's almost like a plastic end of a shoelace that kind of holds it from fraying away. Telomeres are really very important to the integrity of your cells. And what happens, this is my little illustration, that little gray part represents a chromosome. Those little blue niblets on the end, those represent telomeres. What happens is every time a cell divides, a little bit of the telomere, the ends, are lost. It does not fully replicate. And therefore, over time, we can kind of tell the age of cells by the length of their telomeres. And eventually, the telomere will become extremely short, and then the cell is at risk for apoptosis and death. What's really cool is not only age, time, contributes to telomere loss. Race, smoking, body mass index, low exercise levels, sleep apnea, bad diet, all contribute to quicker degradation of the telomere than expected. Also, as a psychologist, I love this, all of these stressful things, high perceived stress, persistent depression, anxiety, childhood abuse, bad childhood illness, interpartner violence, being institutionalized as a child, pessimism, just really terrible ways of being in the world, also contribute to rapid telomere shortening. And it actually begins to look like this is the cumulative assessment of somebody's load of stress. We can actually look at a cell's biological age as opposed to cumulative, chronological age. And so when we looked at all of these factors and thought about our patients with chronic pain, like, oh my gosh, this looks just like our patients. Our patients tend to smoke, they tend to be overweight, they don't exercise, they sleep awful, they don't eat well. And many of them have these horrible histories, long-term depression, anxiety, PTSD, abuse as children. I wonder if these patients have shorter telomeres. And so in our study, we looked at women with really nice phenotyping with good data and also whole blood. And we did telomere analysis on them. And what we found is that there was a very strong relationship between telomere shortening and pain severity, and also telomere shortening and sensitivity to pain. So upon experimental pain testing, the shorter your telomeres, the more sensitive you were, the more vulnerable you were, the more pain you reported, the higher level of pain, the shorter your telomeres. And this is controlling for age and BMI and other factors. There was this really weird and wonderful relationship between pain and premature aging. And this is more pronounced than even it was in depression. So what we did on the y-axis, we have kind of telomere length. As you go up, that's better. You want more telomere length, right? And then we divided our patients into depressed, not depressed. And we saw in the light blue that the patients who were depressed tended to have slightly shorter telomeres than the dark blue patients that were not depressed. But when we looked at high pain, low pain, the difference is much more dramatic. The light blue being having a high pain, and they had much shorter telomeres than the patients who had lower levels of pain. And then we thought, okay, what happens if we look at our data, if we look at high pain and high depression people and low pain, low depression, kind of do this as a combined element to this. And, I'm sorry, I forgot to mention, just with the pain patients, there's about 5.5 years premature aging to observe there. When we looked at the high pain and high depression people, which are on the far left, compared to the low pain, low depression people on the far right, you can see there's a dramatic difference. And what we saw is that the difference between group 1, low pain and low depression, and high pain, high depression, was about equivalent to a little bit more than 6 years of aging, again controlling for someone's actual chronological age. And then no talk is complete without a brain. We looked at the neuroimaging of some of these patients to see if we would see signs similar to what we might be expected to see in premature aging, neural aging. And what this is a parametric map showing the somatosensory cortex. And what we saw was a decrease in brain matter volume in our patients with short telomeres. So basically, it looks like premature aging may be occurring in the part of the brain that's rapidly and always producing or processing pain. We don't know exactly what this means. It's just cool, and it's something we want to follow up on, but it's also just kind of more evidence that something biologically might be going on here. And we weren't the only ones to do this. My colleagues in Florida looked at telomeres in patients with osteoarthritis and found that a similar relationship in their patients. Those patients with osteoarthritis had higher levels of pain and stress, were more likely to have shorter telomeres compared to the others. So let's turn the corner and talk about resilience and positive things. And you're probably wondering why there's a picture of a really ugly tick up here. This is Ixodes scapularis. This is a Lyme disease tick. And this guy taught me a lot about looking at risk and resilience. So when I first started at Robert Wood Johnson Medical School, I was an intern, and I was brought on faculty to help a very senior scientist study Lyme disease. He says, I got the immunology thing down pat. I understand that. What I don't understand are the chronic Lyme disease patients, or these patients with chronic pain. Can you help me study these? And I said, probably the best way for us to do this is let's look at a cohort of hot Lyme disease people who are healthy, came in and have hot Lyme disease. Let's phenotype them, let's find out who they are and what they're like, and let's follow them over time. And that's just what we did. So we identified 99 patients with community who were newly diagnosed with Lyme disease, who had previously been healthy. And we had them fill out a lot of questionnaires so we could assess many risk and protective factors. Predominantly, though, at that time, we were interested in depression and anxiety and symptom severity and number of symptoms and type of symptoms and symptom focus. And we studied them. All these patients underwent significant antibiotic therapy and then followed over time. And what we ended up with at time 2 is we had 72 patients still enrolled. That's 73% of our cohort. And we found that, as anticipated, a large group of them had chronic symptoms, just like Dr. Siegel had said. About 30% of our patients had manifested this chronic Lyme disease, this additional pain and fatigue symptoms. And so what we looked at are the different factors that could be predictive. And we thought for sure depression is going to predict this. No. We thought for sure catastrophizing. People who catastrophize, they have terrible, terrible outcomes in every other medical committee. No, that was not predictive. Negative affect seemed to kind of work. So what we see here on the y-axis is a percent of patients who manifested chronic Lyme disease without treatment. We divided our patients by negative affect group into low levels of negative affect, so relatively healthy, moderate levels of negative affect, and high. And what you see is the patients with a lower level of negative affect were kind of less likely to develop chronic Lyme disease. Those with a little bit more higher levels of negative affect did indeed develop more Lyme disease. But when we looked at positive affect, blew our socks off. Patients with low levels of positive affect were much more likely to develop chronic Lyme disease. And conversely, those that are very high on positive affect hardly ever developed chronic Lyme disease. These patients recovered nicely. And what was really startling is that there was no relationship between positive affect and the severity of the infection at the time. So you could have really bad Lyme disease, be very, very, very sick, and high levels of positive affect, and be more likely to recover than somebody with minor illness and a bunch of negative affect. So these studies taken together tell us kind of four things about the nature of pain. First, thoughts, emotions, and pain are all neural events that are processed by some of the same areas of the brain. Damage and tissue injury is often optional in the experience of pain. Chronic pain may have more severe health consequences than we once thought, so we really should pay attention to it. And lastly, resilience may be more important than vulnerability. So, sorry, Descartes, pain is much, much, much more than stimulus and response. So this is a slide that I love to use with our physicians, and I wonder if you guys can look at these x-rays and put on your doctor hats and tell me which knee hurts, and I'll give you a hint. The knee to your right has bone-on-bone erosion. It is a knee common to patients with osteoarthritis, right? So would you guess maybe that would be the knee that hurts?
Yes.
Who knows? Really, who knows? What is incredible is what we are seeing more and more frequently is that x-rays don't necessarily tell us the truth about pain. So if I were to image all you guys in the front row, do your knees and your back, what I would probably find are some really dreadful looking knees that have no pain and some really painful backs that have no dysfunction or erosion. X-rays don't necessarily tell the whole story. There's something else going on with pain. It is not always about things like bone on bone. And so I'm not going to get into this too much, but I just do want to talk about mechanisms just since we're kind of here and we're talking about the weirdness of pain. Unlike Descartes said, not a stimulus response, there are multiple types of pain. And we as a group spend all of our time thinking about these different types of pain. First, there's peripheral pain. This is pain that occurs in the periphery. It's due to injury or inflammation. It's in the legs and somewhere in the knees, the arms, the back. This type of pain is usually acute. It usually responds well to NSAIDs or opioids. Examples of this are an injury that you might have, cancer pain, rheumatoid arthritis, osteoarthritis. These are all kind of peripheral illnesses. We can usually do something to it and make it better, right? Then there's neuropathic pain. This is a very common kind of impingement syndrome or diabetic neuropathy type of pain. It's pins and needles and tingling, and it's usually some sort of nerve is being squashed and creating the pain. And then lastly, there's something called central pain or centralized pain. And if you are ever out there in the workplace working with a lot of folks with chronic pain that are coming into you, they most likely have a centralized pain condition. And what this usually means is that the pain is no longer coming from a funny-looking knee or an impinged back or some other thing. The central nervous system has actually begun to process the pain signal inappropriately. It is amplifying the signal. And an example I used earlier, have you guys ever had a paper cut? And it gets acutely painful, you barely touch, and you're like, how can this thing hurt so bad? It's a paper cut. It's almost what happens with a centralized pain condition, that the signal becomes very amplified. It just becomes extremely acute. Many patients with chronic pain conditions that we think of like fibromyalgia, chronic low back pain, kind of have this centralized pain state. There's nothing that we can do to fix a knee that's going to fix what's going on with the central nervous system. Therefore, we tend to treat patients with other types of medications and exercise and some other things we'll talk about in a bit. We study very much kind of the centralized pain phenotype, and the sense is that there are people who are vulnerable to chronic pain conditions. There are certain aspects about them that we can kind of see. If I give people a group of questionnaires, I can probably pick 5 to 10 if people are going to develop chronic pain. They tend to be female. It's just more common, but not only. There tends to be a history of early trauma or psychological current trauma, but a stress history. Now think again about these poor little weakened telomeres, the stress history. Often chronic pain tends to run in families, so you'll see kind of some of a familial link, and that appears to be a true genetic familial link. These patients tend to have a lot of stress that comes from negative thinking, from a lot of emotions. Again, it's just kind of creating this physiological milieu that makes them ripe for developing a chronic pain syndrome. And then these patients often have a lot of other things going on, like having some existing fatigue. Our patients do not sleep well. They tend to not sleep well before they manifest chronic pain. So often this person is vulnerable, walking around in the world, kind of genetically and environmentally loaded, and then something happens. There's a car accident. There's a slip and fall accident. There's carpal tunnel. There is an abusive, hideous work environment, and the person manifests a chronic pain condition. And then it almost becomes self-perpetuating. The way the nervous system kind of learns and how it's wired tends to become probably the biggest piece of the problem is the central nervous system. It becomes so ingrained. And thus, that is kind of the genesis. And I'm sorry to give you kind of such a brief view of it, but just so you have a sense. And we look at this kind of across the university. We look at studies in the perioperatives, or we conduct studies in the perioperative setting where we are looking at patients who undergo knee arthroplasty, hip arthroplasty, thoracotomies, hernia repair, and breast surgery. And for the patients who are getting the operation to have pain relieved, we follow them over time to see who gets better. We look at risk and protective factors. Because about 10 to 20% of patients having a total knee or hip arthroplasty aren't going to do real great on the other end. They're going to have chronic pain. We want to know who these people are so that we can get better and decide at the front end who this will be the most effective. Then there's going to be other groups of patients like those who get thoracotomies, a very painful surgery. They didn't have pain before, but after the surgery, about 50% of people develop chronic pain. We want to know who those people are so we can, again, use better analgesic strategies, do other things to help them so they don't develop new chronic pain. Another place we kind of look at these principles is in our pain clinic, where we look at minimally invasive interventions like epidural steroid injections and facet joint injections. Again, looking at these same principles of risk and also protection. Can we see positive affect and other quality of life and social support factors that help protect patients? And then lastly, we do study these things really pretty much across the health system. We have collaborators in just about every niche in medicine, from rheumatology to ophthalmology. There's dry eye patients who have chronic pain that look very similar to our fibromyalgia patients. They look very similar to patients with persistent cancer pain. So that's what we do. But why do we do this? Why do we do this with such passion? It's predominantly for the patients. These patients deserve better, and we think they're at risk, and we think we can do better. It's also for that guy and that gal, the people who are treating these patients. These patients are very difficult, and if you're in a work setting and you're a manager of these types of folks, you may have significant empathy for what our physicians deal with. And to give you a sense, and of course, again, I know you're not a physician, but let me share with you a case. And this is a case that I read to our physicians, and they go, oh my gosh, I know this patient. So this is a 44-year-old Caucasian male who presents with severe chronic low back pain that began in college seemingly due to a football injury. He has undergone multiple back surgeries, none resulting in adequate pain relief. The most recent surgery was complicated by sepsis, which nearly resulted in his death. He is currently prescribed multiple analgesics, yet pain persists. In addition, he is under the care of an orthopedist, a urologist, an otolaryngologist, an endocrinologist, and carries additional diagnoses of irritable bowel syndrome, that began in childhood, and adult chronic prostatitis, headache, myofascial pain, reactive depression, and insomnia. His GI symptoms, namely diarrhea, at times are severe enough to cause total incapacitation. Yet, these are all second to his back pain, which plagues him constantly. Our physicians go, I know this guy, this patient is awful. What do we do? And I say, this patient is that guy. This is a case history that I did with Robert Pinels of John F. Kennedy. Dr. Pinels is a very senior rheumatologist who went and spent 3 days at the JFK library going through all of the medical records and films. And basically, we wrote a paper saying he's kind of a chronic pain, fibromyalgia, low back pain patient. This is very clear. But what is so striking is his resilience. This was the type of patient that we hope all of our patients can become, that despite having this disability, that you can go on and do great things and live with it. One piece of history, too. So John Kennedy's back pain was so severe, he wore a back brace almost all the time. He even wore a back brace poolside when they were out kind of hanging out by the pool. That day in Dallas, when they were riding in the open limousine, he was wearing his back brace. And it has been postulated that the reason that he died the way he did is when the first shot hit him, he leaned forward, and rather than being able to slump all the way onto the floor, the back brace popped him back up. And then the second bullet was the one that assassinated him. So his back pain really may have contributed to the worst outcome. Okay, on a happier note, when we think about resilience of these patients, there are many factors that we study. We look at social support, optimism, self-efficacy, grit, and more broadly, positive affect, because these things all can buffer the experience of pain. There have been incredible prospective and experimental studies that have really looked at how positive affect can spare pain. These aren't just your cross-sectional studies. There's about 500 of those. But these are true, wonderful, experimentally, nicely conducted studies that find that positive affect is associated with having lower overall pain ratings, lower pain intensity scores, better pain throughout the day, week, month, better pain tolerance on testing, less use of pain medication, lower post-operative pain ratings, greater walking times post-surgery, and even length of stay is reduced with patients who are higher in positive affect. A little bit of bad news, though. Unfortunately, for our chronic pain patients, they tend to have very low levels of positive affect. This is a chart showing some means for positive and negative affect scale scores for healthies first. So for a positive affect, you want a pretty high score. So normal is 35. You want to have a score of 35. Negative, for being kind of a normal level of negative, is 18. When we look at patients with arthritis, they look pretty close as far as positive affect and negative affect to healthy people. But our chronic low back pain and fibromyalgia patients both show very diminished levels of positive affect and elevated levels of negative affect. So this, to me, is an opening. This is an opportunity. Can we begin to build resilience with these patients? So what can be done to increase positive affect and enhance quality of life and boost resilience in people with chronic pain? The first thing is a healing environment. And this is something that Paul and I were talking about extensively. This isn't just in medical settings, but also can be in office and business settings. Creating a healing environment where the stress is kept to a minimum, where there's, in a hospital setting, where the lights aren't always bright, and maybe perhaps there's music so you're not hearing all the beeping and buzzing. Temperature is comfortable, the design is a little bit more attractive and homey. Even therapeutic aromas. Smell, aroma is one of our strongest cues to memory, to mood. So, creating a different, a much more relaxing space just by aroma can be very, very powerful. Another experiment that's being conducted kind of across a number of hospitals, I'd love to see us do here. A friend of mine is a pediatric anesthesiologist at the Medical School of Wisconsin. And what he does is he's trained his entire perioperative and postoperative staff to only ask the children about comfort. They don't ask about pain. Their parents are taught not to talk to the child, but not about pain. So when the child is brought out of surgery, the nurses there will ask them, how comfortable are you? What can we do to make you more comfortable? And what they find is that children greatly reduce their use of medications because they're asking for a pillow, for a teddy bear, for an ice cream, for something else besides analgesia. When we ask people about pain, you put pain in there. Remember we talked about how closely tied affect, cognition, and pain are. When you start talking about pain, people think pain. They focus on pain. So a recent study just about a year ago was conducted looking at women who were post-cesarean section, and they randomized women to either a condition where they were asked about comfort scores after their cesarean, or they were asked about pain. How's your pain? What's your pain? And what they found is those in the comfort score group reported less bother from the surgery, less pain and unpleasantness, and requested less analgesics. They used fewer opioids. So this is a very powerful study about how it is that we can do something just a little bit different with our language, something that is more resilience-provoking than negative. And another thing we can do is use many more non-pharmacological interventions than we do. Pretty much, unfortunately, what we do frequently in medicine is give somebody a pill, and unfortunately, it's also the patients who expect a pill. When we know that things like exercise, stress reduction, hydrotherapy, balneotherapy are probably some of the most powerful things that we can do for patients who suffer with chronic pain to keep moving. There used to be a time, again, Paul and I were talking about this, that 30 years ago, even 20 years ago, if you injured your back, the doctor said, bed rest. You got to lay down for 6 days, bed rest. Now we say, keep moving. Don't stop. Keep moving. And then something else that's very powerful for intervention is cognitive behavioral therapy, which has been shown to be more effective than most medications and even functioning. And just to give you an illustration, this is a little study that looked at how well an online cognitive behavioral program for pain would work compared to the 3 FDA-approved medications. Number needed to treat means how many patients do you need to have be on your drug before one of them has the good outcome. The good outcome is just a 30% reduction in pain. Okay, so for duloxetine, an FDA-approved medication for fibromyalgia, it took 7 patients to be treated before one patient would have a 30% reduction in pain. For milnacipran, another FDA-approved medication, it took 19 patients before one patient had a 30% reduction in pain. And pregabalin, the third, same story. 8.6 patients had to come through the door, be treated before one patient had a 30% reduction in pain. It's kind of shameful. In a study of cognitive behavioral therapy delivered online without a therapist, where the patient just said, here, go, do this online, it took 5 patients before one patient had a 30% reduction in pain. This is no therapist. This is not coming anywhere. This is just you play around the internet and try these things. So the significantly bad news is that there's not enough CBT, cognitive behavioral therapy, and these non-pharmacological programs made available to people, and this is kind of our mission. This is what we are doing, is how do we make these things widely available, widely used, easily accessed for patients. As it is right now, there's just poor reimbursement for doing a good job of doing cognitive behavioral therapy or psychotherapy for just about anything, including chronic pain. There's not enough qualified practitioners because it doesn't pay well enough. Its access is difficult because most patients who aren't in these medical academic centers or cities where they can have easy access, and pharmaceutical companies and large entities don't promote fixing yourself using these other types of therapies. So we have begun to do what we can to adapt these and make these things widely available. The goal be to increase our ability to provide tailored chronic pain care, to increase well-being and functional status. So we have developed a couple of websites. So there's one right now that we're working with the University of Michigan and getting up and running. It will be a freestanding cognitive behavioral therapy program that will be available to chronic pain patients that they can use with their occupational therapists or physicians or nurses. We're developing the manuals, and so they can just request them from us. They can go online. It's full. It costs a pharmaceutical company millions of dollars to build this thing. There's videos. There's every bit of CBT. The patients can actually march through it. Our second thing that we're working on is working with Acacia Parks to develop a positive psychotherapy intervention specifically for patients with chronic pain that we will do the same thing for. It'll be available online. There'll be treatment manuals that physicians and nurses can use, and so they can try the cognitive behavioral therapy, which I think is a 1-2 punch. You kind of get people moving, thinking, doing right, and then you enhance them then you hit them with the positive psychotherapy exercises and get them moving. And then lastly, the things that we can really do to help these patients are to really get the multidisciplinary clinics up and running again. This was something that was very, very popular about 10 years ago because it worked great. Patients did so well with these clinics that involved the care of a physician and a nurse and an OT, a PT, a psychologist. You'd have exercise physiologists. You'd have somebody who does movement therapy. You would have a whole team and immerse these patients in these programs and send them out in the world. And they tended to do so much better when you were able to hit them from all angles. But unfortunately, they're very hard to sustain because we don't have the appropriate reimbursement. These multidisciplinary clinics, though, are making a comeback because it is quite clear that they are as effective or more effective than pharmacological therapy, the drugs I was showing you, medical procedures and interventions are very expensive, surgical alternatives really expensive, and these types of programs, these nice comprehensive well-being focused programs result in reduced healthcare consumption, decreased disability claims, increased functional activities. Patients are able to go back to work. They're wonderful things. So we are trying to do our best to create such an entity here because they are few and far in between. Vanderbilt has a lovely one they just got up and running. There's a phenomenal one at Mayo Clinic. Stanford has an outstanding one. I think we need one here. This type of clinic provides care in a very healing environment. It does not look like a medical environment. It's very much taking in effect that it's almost like going to the spa. I mean, it's a beautiful healing place. You do 2-week intensive classes where you attack everything. One of the biggest problems we have with our patients with chronic pain, I've barely spoken about this, is the opioid use and long-term use of very strong opioid medications. And there is an entity called opioid-induced hyperalgesia, which is something else we study at the pain clinic. And what that fancy word means is that the opioids biologically are making a patient's pain worse. And then when we take them off the opioids, wean them off, it's like, wow, they're so much better, plus all the other things that they do. But you use kind of these functional restoration programs to hit patients from many angles, including resilience, building people's ability to self-manage, but also to thrive, because many of these conditions are chronic. And to be able to encourage people, yes, you might have this illness, but it doesn't mean that your life is over, that there isn't joy, there aren't things you can do. And so we spend a lot of time reteaching our patients how to have fun. And that's kind of how we're going to close in a little bit. We're going to work on having fun. And then, again, these programs that are kind of these kind of multidisciplinary clinics that are really inspired by positive culture, positive programming, very much like in business. So we kind of turn to what can be done in work settings. So first is the obvious. Isn't that a funny picture? First is the obvious, is creating safe working environments. And the CDC has a really nice website that talks about the different processes, or they call them controls, that can be used to creating a much more physically safe environment. There's engineering controls, which mean you design the job to take into account humans' abilities and limitations, right? So sometimes we need to tweak what people are doing so that it accommodates them better. There are administrative controls. There's policies and practices that we can put in place to keep people safer, that can help them, that can reduce stress and other injuries. And then, of course, personal protective equipment, and that could be even, ergonomics and things that we can do to decrease repetitive stress injuries, to, use better chairs and adjusting monitors properly. There's a lot of very small things that can make a very large difference. And then when workers are injured, to provide for them the services they need so they can appropriately heal and recover, and even reasonable accommodations in the workplace. Sometimes people just need to get up and walk around for 45 minutes after 3 hours of work, and then they're fine. They can do the rest of the day. Sometimes it just takes time to meet with the patient who has, or the person who has this particular chronic pain condition, and learn what it is that they can do to self-manage their pain and be flexible in helping them. And then maybe the most important thing we do, and for those of you who are so invested in positive organizations, I think this is more important almost than what we do with the physical building. It's the culture that we create. And I was telling these gentlemen that I used to do clinical work. I'm still a licensed clinical psychologist, but I've not worked with patients in a few years. But when I did, what I heard over and over and over again is that patients would be willing to go back to work. Yes, they still had pain and they'd like to go back to work, but they hated where they worked. They had a terrible experience. They were bullied. They had an evil manager. They had, the people didn't like whatever it was. That they were in a toxic environment. So the more that we can do to create positive, empowering environments and cultures, the more likely we are to diminish things like chronic pain when we see these fascinating overlaps between how we feel and how we think. So just, some of the things are no drama hires, picking the right fit right from the beginning. You often have a gut feeling about something. God, I just can't see so-and-so getting along with so-and-so, and you're usually right. But think about the no drama hires. Value kindness. Appreciate each other. Do little exercises so people feel appreciated, understood. Daily huddles. This is something that they talk about and do at Zingerman's, where they all get together and everybody kind of talks about what's going on. And everybody communicates about what needs to be done and who did well. But it's just a little bit of time for everybody to bond before you get on with the busy day. And the more communication often, the better. This is something we do to foster creativity. We have something called skull sessions. And one of our neuroscientists that works in our group has this little monkey skull, about this big. We call her Zira, after the Planet of the Apes. And we'll bring her in, we'll set her on a table, and we'll sit around, and we just think heavy thoughts. And you can think whatever weird and bizarre and wonderful thing, and you can say whatever it is. And some of our best brainstorming kind of comes from these skull sessions, where there's no judgments, there's no limits, you just process. But again, it also builds collegiality, it builds friendship, it builds value. Celebrate victories as a team and learn from defeats as a team. Value friendship and family, understand each other's needs with their friends and their family, and then the family actually becomes the working family. And encourage laughter. Laughter is one of the most powerful healers. When we laugh, we just spurt all sorts of wonderful, happy chemicals that can not only alleviate pain but elevate mood. All good. So I began with kind of a sad little study about people who broke up. So I'm going to end with a study about love. And this was a study conducted by our colleagues at Stanford. And what they did is they looked at 15 men and women between the ages of 19 and 21 who described themselves as hopelessly, passionately, deeply in love. And they brought them in, and like the heartbroken, they stuffed them in a scanner. And they applied pain to the forearms of the beloved as they lay there. And the next thing they did was flash up a picture of the beloved. And when the picture of the beloved was up, the pain didn't hurt so bad, but it was also neurally different. They were processing different. When the picture of the beloved came up, dopamine, the reward systems, became activated. And the pain actually physiologically was changed in the brain. Those are the brains of people in love. So, with that, I want to thank all of my wonderful colleagues and our support staff and researchers that contributed to some of the studies I talked about here in one way or another, and of course our funding sources. And say thank you, and then we'll do a little exercise.